First off, welcome everybody. Thank you so much for joining us. My name is Joe Berrigan. I work as a Director of Leadership Gifts with the PKD Foundation, and I'm going to be your hospitality host for this session. You've joined us for transplantation from evaluation to transplant surgery. Before we get started, if you have any questions during the presentation, please type them into the chat box and we'll address as many questions as possible during the Q&A. I'm going to be furiously taking notes to try and make sure we get them down and I am able to repeat them correctly. We'll also ask that you please keep your microphone muted throughout the session to help ensure good audio quality for everyone in attendance. And with that, I'm pleased to introduce our speaker for this session. Dr. Patrick Dean is the Surgical Director of the Kidney and Pancreas Transplant Program and a consultant and associate professor of surgery in the Division of Transplantation Surgery at the Mayo Clinic, Rochester. Dr. Dean's clinical and research interests include kidney and pancreas transplantation, preemptive kidney transplantation, living donor kidney transplantation, transplantation for PKD, and more. Dr. Dean, it's my pleasure to turn it over to you.
Well, thanks very much, Joe, and thank you for those of you who are attending. It's really a privilege to get to talk to a very engaged group of patients who take their health seriously and are very motivated to get what ultimately many of you will need, and that's a transplant. This will overlap a little bit with what we've talked about before in the preemptive kidney transplantation with Cliff Miles and the other rest of the members. So it's a bit redundant in a way, but and if you've been to this conference in prior years, this is a little different than I've done before, but hopefully you'll enjoy it. I'll be sharing my screen here. So as Joe said, what we're here to talk about is really the process of what happens when you start your evaluation for a kidney transplant, what happens between then and when you ultimately receive a transplant. And this is not meant to answer every question. Hopefully it'll be a good general overview, and then we'll have plenty of time at the end for your own questions that are specific to your case. I don't have any disclosures to report in this educational activity. A lot of patients want to know when they should start preparing for a transplant. I think, you know, it's usually not a surprise for most patients with PKD that they may face this during their lifetime. And it's something that, you know, there is a bit of time to get your head wrapped around the fact that you may need some sort of therapy, whether it's dialysis or a transplant, some form of renal replacement therapy. Many people know this or have it at least in the back of their head for years when they have PKD. They've seen family members go through the process. Unfortunately, I've seen family members die while waiting on a transplant or on dialysis. So it's usually not a tremendous surprise. There's the rare case, certainly, you know, we occasionally see people that are diagnosed relatively late in the disease, and that's usually what we call the index case of a family, because every family needs to have that mutation or one of the mutations to start the process of PKD, but it's usually not too much of a surprise. So I think it's probably a good idea to start at least mulling the ideas over in your head when your GFR is about 30 or less. It's probably not going to be an emergency that you need a transplant or dialysis. Most patients with polycystic disease, their decline in GFR tends to be generally somewhat consistent and not rapid, if that makes sense. So sort of you have some time. The other thing is a lot of people with PKD are generally otherwise quite healthy, and they may feel pretty well even with a GFR of 10. So I don't think there's a magic number that says you need to have a transplant now, but at least start wrapping your head around the process when your GFR is less than 30. Often asked, people want to come for an evaluation when their GFR is 28. Probably don't need to at that point, but maybe when it's around 22, 25. You're not able to be listed or placed on a transplant waiting list until your GFR is 20 or less. So that's kind of the number, at least from a listing standpoint. You can certainly come for an evaluation prior to that, at least to get the information, but really not any need when you're 40 or 45 or 50, somewhere in there. For those of you that were able to attend the preemptive session, you don't have to be on dialysis before you need a transplant. So that's why it is important to start getting your head wrapped around it and getting things moving. The process isn't, instant. So you have to be evaluated for a transplant. Then we start talking about living donors and that sort of thing. And none of this happens in a week. So it does take some time to get these things accomplished. The evaluation itself will vary across centers. I think there are right around 250 kidney transplant centers in the country right now. So each of these would have their own approach. Some of the evaluations, for example, ours is about a 2 to 3 day visit, usually determined if you need an extra day to do dialysis when you come. But some programs space it out a little more and have it done over a period of a few weeks. But generally, it's not, a 6-month process to have your evaluation. But you typically will visit with the transplant center at least once. It used to be that we had people coming, 1 or 2 times, but now we actually reach out virtually a fair amount with our initial evaluation with a nephrologist, and then have people come to Rochester to complete the evaluation and meet in person most of the members of the team. So that's actually been one, I think, good side effect of having to change the way we practice in the last year and a half. It has allowed us to, if you're in California, we can do a lot of it, and that actually shortens the time you spend in a town like ours. Of course, if you live in San Francisco, across the street from the University of San Francisco, you can kind of do it whenever you want, but most people don't. The evaluation is generally divided into sort of 3 main components. It's a medical evaluation, it's a surgical visit and evaluation, and then you'll spend time with our coordinators, our social workers. Some centers mandate psychiatry evaluation, most don't. But if there are any psychiatric needs that need to be addressed, we're happy to address those. I call it sort of a 100,000-mile tune-up because it's a very thorough evaluation. And the medical side of it is really focused on, will you benefit from a transplant? And, if you look at anyone who gets a transplant compared to people that stay on dialysis, transplant's a better therapy in general, but it's not necessarily for every single patient. Fortunately, most patients with PKD, it's a relatively straightforward question, but there can be issues that we need to address. The medical evaluation really focuses on, your risk of being able to tolerate an operation, which is not the world's biggest operation, but it's a decent sized operation in the scope of things, and hopefully be able to live a long and productive life afterwards. And so we'll talk a little bit, there are very few things that would really eliminate somebody from being considered for transplantation, but sometimes we do try to correct things or improve things to help, the better shape people are going into it. From a cardiac standpoint, for example, people with coronary artery disease or prior heart attacks, those sorts of things may be able to be improved and help improve their outcomes. Most centers, if you have PKD, will have a little bit, it's different than the patient with diabetes and kidney failure. They have a whole other list of things they need to address. But, certain families and have more common incidents of intracranial aneurysms, of aneurysms of the brain. So many transplant centers will screen PKD candidates for that. Some have having been to the meeting in person, I know this to be true. Many people do have significant polycystic liver disease, and there are certain therapies and rarely even liver transplant that are needed for those. And then, it's always been a question for PKD patients, but what should we do with my own old kidneys? We'll talk a little bit about that through here. But so those are the sort of PKD specific focus that your evaluation will have. The surgical evaluation probably is your shortest visit during the 2 or 3 day or however long it is process, but really we're focused on anatomy, and have you had 2 or 3 prior transplants? Hopefully not, but we do see that. Any operations on your native kidneys, cyst fenestrations, those sorts of things. or resection, liver resections perhaps. And then we're really, again, focused on, how straightforward is the operation going to be? It doesn't have to be perfectly simple to be approved for a transplant. In fact, sometimes it's fun if it's not on the surgery side. But, we look at make sure the blood vessels are suitable for implanting a new kidney. And then examine the native kidneys. There are rarely, and we'll get into that in a little while, but there are rarely patients that have such big polycystic kidneys. It's just probably not feasible to put another one in. That's very uncommon, but there are, as we'll talk about, other reasons to remove them rather than just purely for space. The psychosocial evaluation, life's complicated and everybody doesn't come to us or, just whether they need a transplant or not, doesn't have a perfect past to where they've come to in their life. So we specifically address things like mental illnesses, chemical dependence, whether it's alcohol or non-prescribed medications. Obviously, we want people to have as good a family or social support as they have. It's very important to have people help walk through this journey with you. Many places will refer to this as a caregiver, especially around the time of the transplant. So it's important that we can have somebody to help you out when you may be a little bit off your feet for a few days or weeks. Financial resources are also addressed. Certainly, transplant's not free. We wish it were, but it's not. And there are folks that really we almost bankrupt with a transplant if they're on medical assistance and those sorts of programs. They still have a fairly significant out-of-pocket expense. But so we address their financial concerns as well. And then obviously we want to make sure people are fairly compliant with what we recommend as medical therapies, and that mostly after transplant relates to maintaining good general overall health and then taking your immunosuppressive and other medications. Generally, this isn't a huge issue with our PKD candidates, but it certainly can be with other groups. As I mentioned, there are not that many things that will really preclude you from getting a transplant, but some might delay them. Many times we are not able to transplant people as soon as we want because they have a recently diagnosed or treated cancer, such as a lung cancer or something like that. But however, there are some cancers, things like prostate cancer, where certain types of prostate cancer, where your survival at 5 or 10 years is really quite good related to that disease, and we don't necessarily have a waiting time. So you might have heard or had family members that had to wait 3 to 5 years because they had a cancer. That depends really on the type of cancer. Chronic illnesses that would, have a very poor prognosis within a couple of years might be an issue. That's pretty uncommon in candidates with PKD, though. We do unfortunately see folks with pretty poorly controlled or uncontrolled mental illness, things like bipolar disorder or schizophrenia would be the more common ones we see. We're going to talk a little bit about obesity in the next part of the talk, but probably most transplant centers that you'll come across have some sort of criteria for how big a person can be to receive a transplant. That's usually based on body mass index, which most of us realize isn't the best way to necessarily measure fat distribution or obesity, but it's probably the easiest to calculate because all you need to do is the height and weight. You can go to Google and find a lot of calculators that will allow you to enter that in metric or English system. And you can calculate your body mass index. Some centers have, for example, 40 as the BMI cutoff. Others are a little more constrictive and their cutoff is 35, with some latitude given to certain patients. But generally, those are the two most common cutoffs. Inability to remember to take medications, even that is not so much of an issue. I mean, we certainly transplant people that have significant developmental delay and those sorts of things, even as adults. And if they have an adequate support system, we're able to do the transplant. And then current drug or alcohol abuse sort of relates to mental illness. There are people though that are able to go through rehab and ultimately get a transplant. those are the more common things that might delay things. So once you're approved at a center, you go through that process of the evaluation. And some of this can start before that. There's no law against starting earlier, but I think, how do you really prepare for a transplant is an important question. Whether you've just been listed or even if you've been waiting for a year or two on a waiting list. This is probably this, and I steal this from my wife. She's an endocrinologist, and so she talks to her patients about TLC. Give yourself some TLC, and there is another marketed program that talks about TLC, but this is a little bit different. So this is therapeutic lifestyle changes, and things we can do to, as I mentioned before, the better shape you are going into a transplant, the better chance you're going to be in good shape coming out of one. And this is true whether you're having heart surgery or a transplant operation. But increasing physical activity is very important. If you tend to be more sedentary, even starting to walk around the block and things like that can be helpful for your lungs, your hearts, your bones, your joints, your muscle tone, those sorts of things. Unfortunately, it's not a great way to lose weight. And we'll talk about that in a little while. Hopefully some of the nutrition talks, and I didn't attend them, but in the past, they have been very good, but they talk about eating healthy. We want to make sure your things like your cholesterol, especially your LDL, are well controlled. One great way to do that is to decrease your intake of saturated fats. Probably everybody on the phone knows that low sodium is important from a blood pressure standpoint. It doesn't affect a lot of other things, but certainly it affects blood pressure, and blood pressure control is quite important. And keeping good control of your blood pressure may actually help at least not speed up the progression of one's kidney disease. Tobacco use is a very common thing in this country, whether it's in the form of smoked tobacco or chewed tobacco. But if you can, it's really important to try to stop that. Even quitting smoking a week or two before an operation has been shown to improve outcome. And then weight loss, we're going to spend a bit of time talking about this, mainly because it's, and as I'll show in a slide or two, it's become a very prevalent issue in this country, whether it's patients we see and even in our donor clinic, we see a fair amount of overweight and obesity, but certainly in the kidney transplant world, it's become a big issue, and it is important to try to lose weight. As I mentioned, physical activity is not a fantastic way to start losing weight. It is encouraged for all the other reasons I mentioned, but just for an example, if you run, or even for that matter, walk a marathon, you burn about 1 pound's worth of calories. And so most of us are just unable to achieve that type of exercise on a routine basis. If you're Michael Phelps or one of the elite athletes that are on NBC every night now trying to qualify for the Olympics, that's a different story. They probably eat whatever they want because they're training so hard and burning so many calories. But most of us just, we have jobs, we have family, we just can't do that. So it's really important to try to limit our amount of calories. And if you're trying to lose weight, and these are just general guidelines for most men and for most women, it's quite restrictive, unfortunately, but it's really about 1,500 calories a day for men and about 1,200 calories a day for women. And that, if adhered to pretty religiously, will usually result in losing 1 or 2 pounds a week. Again, not as fast as most of us want either. It's challenging even to lose 10 pounds, but it can be done. It's just, it takes really changing the lifestyle. This is where our country was 2 years ago. These are the latest data, and you can pick out your state. If you live in Colorado, you don't have to pay attention to any of this, or I guess in Washington, D.C., but most of the rest of the country does. And the colors denote the percentage of people with what's considered obesity, and these are based on BMI, and that's a body mass index of greater than or equal to 30. And so if you look, I'm from Alabama originally, and the Deep South is struggling with obesity for sure. So over 35% of patients in all of this maroon color or brownish color are obese. Here, where in the Midwest where I work now, it's certainly 30 to 35% of patients. And this is all comers. This isn't just transplant patients. The Mountain West tends to do a little better with only a fourth to 30%, but it is an increasing issue in the country. The reason we do recommend, if this is an issue for you, if it's not, you can turn off or tune out for a bit. But things that obesity affects are certainly things around the time of the transplant, things like complications related to the incision, whether it's an incisional infection or a wound infection, or a hernia where the abdominal wall muscles are sewn back together. Some of you may have hernias, belly button hernias or groin hernias that have to be repaired just because of the increased pressure of the native kidneys. And so we probably do see a higher incidence of hernias in our polycystic population. But probably more importantly, those are certainly, definitely inconvenient and definitely not ideal. But the long-term things are really what we're focused on. And that's the risk of developing diabetes after the transplant. That's been mostly associated with weight. There are some of the medications we use that predispose people to this. Even certainly steroids have been attributed to that or implicated in that over the years. But there are many patients now that are on a steroid-free regimen that still develop this. Some of the drugs like Graft that you may have heard of can increase that. And it also, we want to decrease the risk of any medical complications after the transplant. Certainly, if people do develop diabetes, they're more likely to have things like heart attacks. And then obesity and just in general is more associated with certain types of cancer. So people that are obese are more likely to have many different types of cancer. And it's really spread out all the way from, things in the gastrointestinal tract, like the esophagus, the stomach, and the colon. Females that have excess body weight are more likely to have uterine cancer or ovarian cancer. Breast cancer is more common, as are some blood cancers, kidney cancers, thyroid cancers, and meningioma of the brain is not necessarily a malignant tumor, but it can certainly cause problems if it's in the right place in the brain. So these are the reasons you may hear people talk to you about trying to at least get down to a relatively normal weight prior to transplant. There probably is a bit of fudge factor for large kidneys. We're going to show some examples of kidneys later. Certain people have massive kidneys. Others have, and with polycystic disease, have kidneys that are maybe only 3 times the size of a normal kidney, but they might weigh 1 kilogram or 2. So there probably is a bit of a fudge factor built in for kidneys. So once you've been approved, there's sort of 2 main ways to get a kidney. There's living donor kidneys and deceased donor kidneys. We used to call these cadaver kidneys, but the nomenclature has changed. From a living donor standpoint, really anyone can donate a kidney to you. They can be siblings, which sometimes is an issue in polycystic families, kindreds, because either siblings have either donated to a parent or to another sibling, or they may have the condition themselves. So the sibling pool might be a little more narrow, but certainly parents, spouses, friends. We have people come from church. We have people come from all over. There's really not an organ shortage in the country right now. There are 300 million people that are adults that live in the country, and there are only 100,000 people waiting on a kidney. So it's really a willingness of a shortage of willing donors, I suppose, but the numbers could make sense if things were done in the right way. Then deceased donors are kidneys that are removed from a donor who's either experienced brain death or cardiac death with really no chance of neurologic recovery. So 2 main types of deceased donors also. The general consensus in the transplant community is it's probably best in most cases to find a living donor if possible. And as I mentioned in the earlier session, if you're unable to identify a living donor, it's nobody's fault. We have people come to us that have 7 or 8 potential living donors, and those people can't donate for one reason or another. And that's not certainly not the candidate's fault, the recipient's fault. It just is. Then we have people that come to us that don't really know anybody that's interested in donating a kidney to them, and that's not their fault either. So I don't want this to come across as critical in any means, but for those that are able to do it, finding a living donor can help avoid dialysis, and that's that preemptive kidney transplant we talk about. The waiting time is going to be much less shorter, as we'll talk about in a little bit. Most of these living donor kidneys will work, most meaning probably 98% will work right away and avoid the need for any post-transplant dialysis. And that's compared to deceased donors where about probably at least a third, depending on the program, will need some dialysis after the transplant. It doesn't mean that deceased donor kidney is not going to work at all. It just means we have to do dialysis until it recovers from the basically shock of being taken out of one person and brought to someone else. And in general, they tend to have better long-term survival. And that's mostly because we probably know a bit more about our living donors, or quite a bit more than we do about our deceased donors. If everyone had it'd be a tragic situation, but if everybody had an 18-year-old deceased donor, this probably wouldn't be the case. Those kidneys would probably last a really long time. But these are the sort of graft survival rates. If we look at all people that have a living donor transplant in the top row here, 10-year survival meaning of the graft of the kidney, meaning the patient hasn't required dialysis or a new transplant, is about just under 2/3. And whereas for deceased donors, that number at 10 years is about 50%. So there is a difference. If we look at all comers, again, there's probably, we don't really have the math to say, if I put this kidney into you, how long will it last? But the other way to look at this is on average living donor kidney transplants, the median survival, meaning half less longer and half less shorter, is about 14 years for living donor kidneys, and for deceased donor kidneys is about 9 or 10 years. So on average, living donor kidneys do last longer. If there's not a living donor option, then we get to the deceased donor option. And I mentioned earlier, there are only about 100,000 people waiting. It's actually only just under 91,000 people as of a day or two ago. But that is compared with just under 18,000 deceased donor transplants that were performed in 2020. 2020 was actually, despite a lot of issues that most of you have lived through, certainly it was for transplant, actually, especially in the deceased donor world, it was certainly not necessarily a really slow year. There was some pause and some consternation that occurred in March and April of last year in the States. But there were some programs that were profoundly affected, but at least nationally, it was not a terrible year for deceased donor transplantation. The number of living donor transplants did decrease a bit. And so last year there were only 5,200, and that had been down a little bit. Just so where you can kind of see where you sit, in the green here is the diagnosis of polycystic kidney disease. It's a relatively small proportion of the overall group of people waiting for a kidney. And this number has been pretty consistent over the years, at about 6% of people that are on the kidney transplant waiting list. So, and the others is everything from diabetes and hypertension to other, kidney diseases, specific kidney diseases. So, but it's about, you're in the sort of 6% bucket overall. Waiting times are a fun topic because they're so hard to get a real good handle on. And I'm not an expert on what happens across the nation where you may live, and certainly in other countries, because I know there's a fair amount of international attendance at this. But around where we live here in Minnesota, the average waiting time depends upon a person's blood type. And if your blood type is AB, you're sort of lucky in that, oh, sorry about that. You're a little bit lucky in that your waiting time's shorter. This is also a good place to be if you're in the market for a living donor, because anybody from a blood type standpoint can donate to you. But then the other times range from blood group A, which are 4 to 5 years, and gradually increase about adding a year or so to that range for O and AB. Or O and B. So certainly it's a long time. probably some or all of that time would be spent on dialysis, but it's not forever. So keep hope. And then, it ultimately should happen, but it is unfortunately much longer than we'd like it to be. Some areas of the country, these numbers are 10 to 12 years. But I know best where we are, so I can't comment too much about those. Living donors is a popular topic at this meeting, as it should be. And just so folks know, though, we're not, as a transplant center, allowed to contact donors. Some folks come to us and say, well, now you need to find me a donor, and that's not really our role in this. In fact, it's actually illegal for us to solicit donors. But the donor generally contacts us. Each transplant center will have their own sort of entryway into that process. Many now are a web-based screening questionnaire that certainly has, very broad criteria that might or might not exclude a person from donating. And then if you get through that hoop, then you might talk to somebody from the transplant center, one of the donor coordinators. And then if they get through those hurdles, which hopefully aren't too big of hurdles, but they come to the transplant center to be evaluated. That day, similar to the recipient or candidate evaluation, is about 2 to 3 days. And then ultimately, if approved, the donor themselves decides whether he or she wants to donate. It's not, there can be certainly no coercion from the transplant center, and hopefully no coercion from the potential recipient. There are ways to sort of increase living donation. As I mentioned, there are a lot of humans in the country, but we'd love to have, get rid of the waiting list with living donation. Certain programs will use donors that have mild high blood pressure or hypertension. Usually that's well controlled on one medicine, or maybe a combination of 2 medicines, but certainly that's one way, but every center probably doesn't do that. Historically, meaning 10, 12 years ago, there was a lot of emphasis on blood group incompatible, or what we called positive cross-match transplants. Those are still done, but one of the really exciting things in kidney transplantation in the last, certainly in the last decade, has been what's called kidney paired donation. You might have heard to it as kidney paired exchange. And those programs in many ways have eliminated the need to do these sorts of things, but not for everybody, so they're still done. But kidney paired donation is an exciting concept. I'm not going to endorse or tout one program over another. You'll find programs that have their own internal, and that's how many of them were started, actually, was programs would do it within their own center. But there are at least 2 or 3, including a UNOS program, which has been a little less popular, but things like the National Kidney Registry, Alliance for Paired Donation, and then a match grid program that are able to facilitate these transplants. And the simplest way to think about kidney paired donation is exhibited on this slide. So if I'm recipient 1 and my blood type is A over here, and my wife wants to donate and her blood type is B, that would be incompatible from a blood type standpoint. But say somebody else at that center or elsewhere in the country has the recipient is blood group B, and their potential donor is blood group A, then donor 1, who's blood group B, donates to recipient 2 that's blood group B, and similarly with donor 2 to recipient 1. And this is really the simplest iteration of kidney paired donation. But we do kidney paired donation for blood types. We do it for those of you who have been to transplant centers might have heard about antibodies against tissue types, or people with a high CPRA, calculated PRA. So these antibodies attack the tissue types could attack the tissue types of the donor and cause problems. And so a lot of times you're able, with these paired donation scenarios, to avoid that sort of transplant. Sometimes it's done for age. For example, a child whose only real suitable living donor might be their 65-year-old grandmother. Might not be the ideal kidney for that child, but may be a fantastic kidney for some adult on the waiting list. And so there are a lot of different reasons these things can be, and they can get quite complicated. They can be, these are the sort of things that you read about a few years back, you know, the 16 chain and that sort of thing. And mathematically, you can actually, you know, come up with a really long chain that can be done. But this is a very nice option for people that do have an approved or suitable living donor as well. There are lots of different ways to find a living donor. You know, I think one of the good points that was brought up in the preemptive discussion was that it's probably really hard to ask somebody to donate a kidney. But the more people that know your story, probably the more people that are likely to donate, or at least come forward to donate a kidney. This is sort of old school way of doing it, you know, billboards, pretty low tech billboard here, but hopefully effective. But certainly billboards used to be done. I suppose this is the newer version of that. So social media has become a pretty common way of people to look into donate, or at least let people know that a loved one or even themselves needs a kidney. You know, these media platforms have their downsides, but they get the word out. And so you know, a lot of our patients will use this if necessary. But again, it's just about getting your story out there. As I said, it probably is hard to ask somebody to do this yourself. I personally, a very private person, I probably wouldn't, you know, other than my nephrologist and me and my wife, nobody would even know I needed a kidney. But, you know, my wife would be a very good recruiter for me, I think. She's very outgoing and very convincing, at least at home. So hopefully, you know, you can find somebody to let people know your story. And as I said, social media is tremendously powerful, to the point sometimes we have so many people, we'll have 100 people fill out our at least initial survey for a particular recipient on. So it gets a little logistically challenging on our end to screen through all the potential donors, but certainly it's a way to get more donors interested.
This is your event staff checking in with 9 minutes remaining for our session today.
Okay. Well, then we can, I mean, the operation itself is pretty straightforward, just like any other kidney transplant. We, you know, make a small incision, relatively small incision on the front side of the abdomen. We don't usually see the old kidneys unless we're intentionally removing them. This is what a new kidney looks like. This is a nicely well-perfused kidney. The patient's head would be up here and their feet would be down here, but this is really what it looks like. The risks of surgery are like most surgeries and being in the hospital, things like infections, bleeding can occur, but it's pretty uncommon. Rejection is a pretty uncommon thing, certainly rejection that we lose the kidney to, but you know, it can happen in the first few months. It doesn't happen very often in the first few days anymore. It used to. So we'll talk a bit about your own kidneys. Really, the main reasons to remove them are symptoms. If they're not causing much problem, we tend to leave them alone. But the symptoms people have are usually, you know, severe discomfort or pain, often to the point that it's, you know, lifestyle limiting or that people require narcotics. Some patients have a early satiety, meaning they don't eat, they get full really quickly when they eat. This is also common in patients with significant liver disease. There are some folks that have infections or bleeding from the native kidneys, and that can be really troubling and problematic for them. And so that's a good indication to take the kidneys out. Rarely, I mentioned needing space for a new kidney, or the allograft is just a fancy word for kidney. And then really uncommonly, partly because they're so hard to take pictures of, are patients with PKD that have a mass on one of the kidneys that might be suspicious for a cancer. This is a bit what I was getting at earlier. This is a CAT scan. So the patient's head is up here and the feet are down here. These are showing two polycystic kidneys that aren't really causing any problem in this patient, and they're outlined in yellow. And then the new kidney is lower down in the pelvis, outlined in green. The other extreme of this is this patient who has massive kidneys. I'm not showing his, although he's given me permission, I'm not showing his side profile real photo, but these are massive. And this was a patient that actually we took the kidneys out at the time of the transplant, partly for room. And obviously these were quite symptomatic. You can see his belly is all kidney because this is the abdominal wall on the outside of this yellow, and it's really only a centimeter or two thick. Our own approach at our center, and each center may be different, is to, if they are symptomatic, we will try to remove them at the time of the transplant. It makes for a longer operation, but at least it's just one operation. But if that's not what a particular center chooses to do, they can be removed later after the transplant, or they can be removed if they start to cause symptoms. This is a picture of my partner, Dr. Prieto, who's currently in Spain, where he's from, but this is one of the polycystic kidneys he removed in one of our recipients. He's able to do this through a small, like 7 or 8 centimeter incision and laparoscopic instruments. So it is an option, but it's not necessarily for everybody. Probably in our center, we'll remove the native kidneys in about 35 to 40% of the patients. So just to summarize, try to get to a center early as you can, but not when your GFR is 40, but maybe 25 or so. Try to maintain your overall health. Ideally find a living donor, but recognize that it doesn't always work out that way. And telling this group isn't necessarily necessary, but certainly informed patients are the best patients for us to work with because they're really engaged in their care. So, and with that, I'll be happy to answer any questions. I can leave this up. Email probably the best way to get a hold of me. So anytime I'm happy to talk about, or you can call, that's my office number. You're welcome to call, and I'll be happy to talk to you about transplantation, any questions you might have. Joe, what sort of questions do we have?
Yeah. Well, thank you so much. So we've only got a couple minutes here, so I think we'll probably get to a couple questions. But thank you for including your contact information.
Sure.
And if you do have other questions, anybody following along, you can feel free to email us at pkdcure@pkdcure.org. We can't answer any specific medical questions that can help direct you towards finding answers. So I just want to say that very quickly. So a couple of questions we had is one that was a little bit more specific, had to do with, does a negative RH factor play a role in blood type compatibility for a transplant?
No, that RH factors are mostly used for pregnancy and for blood transfusions, but for solid organ transplant, it doesn't matter at all.
That's a nice, quick, easy answer. Is there an age limit for people to receive a transplant, or a general sense on that?
Some centers you contact may have a strict age limit. We don't, partly because, I'll see people in clinic that are 50 who look less healthy than somebody who's 75. So at some centers, there's no absolute cutoff, but if you get up into your 70s and 80s, you have to look really pretty good in order to receive a transplant. You have to be pretty healthy otherwise, which often, especially kindreds that tend to be, of the PKD2 gene variety, which presents a little less severe, maybe later in life. We see quite a few of those folks, and they, in their 70s, and they can be very good candidates.
This is a pain-related question. Someone asked if pain factors into any sort of transplant decisions outside of GFR. So if GFR is still a certain level, but experienced because of the size or pain someone's feeling, does that ever factor into the decision of whether or not someone could be approved for transplant?
It can. Yeah, it certainly can. Not when the GFR is 60, but people that are in their high 20s probably could be considered for a transplant. And when your native kidneys are removed at the time of the transplant, your GFR is 0. So you certainly qualify after that, but from a strict paperwork standpoint. But yeah, on a case-by-case basis, if the pain is really that severe, it can be considered, yeah.
Well, I think that's all the time that we've got, today for questions. But thank you, Dr. Dean.
Sure.
And thank you, everyone, for attending. I hope you're enjoying the conference.